All right, good afternoon, everyone, and welcome. We'll just give it a few more seconds as everyone joins us today. All right, let's get started. Well, hello, everyone, and welcome to our 9th webinar Wednesday on November 2nd. My name is Ashley Caesar. I am the Programs and Events Specialist here at Digital Health Canada. All right, so today's webinar Wednesday is how innovation helped one Toronto clinic cut overhead costs in half. And it's a pleasure to introduce you to Adam Pimentel. He is the head of sales at Chime. All right, so we will have time for Q&A at the end of today's presentation. So please type your questions in the chat box at any time. All right, thank you all again for being here today. A warm welcome to all of our attendees. And I'll now pass the screen over to you, Adam.
Awesome. Thanks so much, Ashley. I appreciate it. And let me go ahead and pull up my screen here. Okay, great. So first of all, thanks everyone for coming. I appreciate it. My name is Adam Pimentel and I head up the sales team for Chime. Now, I've learned from speaking with customers everywhere that skyrocketing overhead costs are a ubiquitous problem within Canadian healthcare. It's not hard to open the news and see yet another headline talking about inflation running hot, while revenues stay flat. So I'm excited to have the opportunity to share today's case study with you. I hope everyone finds something useful as a takeaway. So let's start by setting the stage. We'll be speaking today as if you're someone with an interest in reducing the overhead costs of clinics, whether we're talking about a standalone primary care clinic or a fracture clinic located within a hospital. There's a million and one reasons for why this might be relevant for you. I don't think I need to get into those details. As I mentioned, my goal is that everyone leaves here with at least one nugget of insight, something useful as a takeaway that gets them thinking. This means we're going to cover quite a bit of ground quite quickly. So to do so, today's webinar is really a case study of a client of ours in Toronto and how they've innovated by borrowing outside healthcare to achieve 50% savings in a core metric, their cost per appointment. So if you have any questions, absolutely please add them into the Zoom Q&A or the chat. We've set aside lots of time at the end to answer questions, so don't hesitate to ask throughout. So today I'm going to try to cover 5 topics. The first is to briefly introduce our client and discuss their key problem. And then I'll turn to 4 innovations from outside healthcare, such as grocery stores and Uber, that they used. If it's not obvious, I'm here because Chime, our technology, played a key role in enabling each of these innovations. Although the real kudos should go to the clinic, our job was just to provide the technology that needed to affect real business change, which is the far harder challenge in healthcare. Let me start with the client and their key problem. So the client is a multi-location family practice in urban Toronto. Before their implementation of innovations we're discussing today, their stats were pretty typical of what was considered a full clinic that didn't have room to grow. You have 11 exam rooms at 2,600 square feet, 7 full-time equivalent physicians, with at most 5 seeing patients at any one time, 1 receptionist, 2 MAs, and a nurse. In total, they were seeing roughly 90 appointments a day, which works out to roughly 1,500 a month or 18,000 appointments in a year. The fact that the location was considered full is pretty key. By traditional metrics, assuming traditional practices, the physicians practicing here would have complained bitterly if more physicians were onboarded. There just isn't room, is what they would say. Now, these numbers are a bit outdated because they're from a number of years back and aren't inflation adjusted, but let's review their pre-innovation stats. So taking into account just their base operating costs to keep the lights on, what are rent plus equipment plus people, without even taking into account things like supplies, management, and technology, this clinic was experiencing an effective cost per appointment of $17.67, which added up to roughly 2/3 of their total operating budget. I would need to go into other details such as the revenue per appointment and the average length of appointment to really unpack this number, but I'm just going to skip those details and just say this cost per appointment was a problem. They were running in the red for sure. I'm going to skip ahead and share the outcome here. The orange line, this is their estimated effective cost per appointment. You'll see how it was roughly $17 to $18 per appointment, and over the course of 18 months or so, drops to about $8 per appointment. The blue mountain there in the background represents their appointments per month. You'll see how it goes from roughly 1,500 to just over 3,000 appointments a month. Now, to be clear, this specific data was from pre-pandemic and primarily had to do with in-person appointments. We've actually worked into this presentation some additional improvements they've made during the course of the pandemic, which means these exact numbers aren't entirely accurate, but I think that's okay. It gets the point across. And by the numbers, this is how things worked out. Most of the costs stayed the same. There was actually a slight reduction in support staff, and despite the dramatic increase in volume, resulted in an effective base overhead cost per appointment of roughly $8 instead of $17. By any measure, I think this was a pretty successful transformation and why we're using this clinic as our case study today. Okay, so I think that's enough of an intro. Let's turn into the specifics of what actually made this possible and look at our first innovation, which has to do with staffing. So how are clinics traditionally staffed? Well, it's pretty simple. Different people have different roles at the clinic, and typically you would need a warm body in each role for the clinic to operate. The traditional solution is simple as well. One shift, 9 to 5, and a 1-hour lunch, right? This gives you 7 patient hours a day. That's 7 hours a day out of 24, where physicians are actively seeing patients out of exam rooms. Okay, so let's look at this. What about grocery stores? There's 3 things I'm going to highlight. The first is how the shifts are much more staggered. There's completely different staffing at different times based on how much a customer demand there is. The second is how staff are cross-trained. Instead of focusing on dedicated roles, people can be shifted between roles based on real-time demand. Like the Saturday morning rush is here, everyone to the tills, that kind of thing. The third is everyone's favorite love it or hate it technology, self-checkout. Grocery stores have been experimenting with this for years, and it's a juggernaut of an industry trend. While each change is relatively minor, borrowing these strategies meant this clinic was able to open earlier, close later, and be open through lunch. By the numbers, this meant seeing patients 10 instead of 7 hours a day, a 42% daily increase without hiring more staff. Not a bad outcome for a clinic that was previously quote unquote full. The practical challenges, of course, were those low staff periods. Can a single cross-trained staff member run a clinic, even if there's relatively low demand? Well, this is a first example of how Chime, our technology, played a key role in enabling this clinic's innovations. In particular, machines at a grocery store, they used our virtual patient escorts to guide patients to rooms and our virtual receptionists to self-check in those patients. This meant that a single person working in the early morning isn't truly alone. They were supported by these technologies handling 95% of patients automatically, making it possible for that single individual to effectively run the clinic since they only need to handle the 5% of exceptional situations personally. Okay, I think we're making good time, so let's move on to hot desking. As a reminder here, everybody, if you have questions, absolutely please add them into the chat. I think I see one in there already. We've set aside lots of time at the end to answer them, so don't hesitate to ask away throughout. I'm sure a lot's going to pop up for you here. So, how are exam rooms in clinics traditionally assigned? My experience is that this varies between the types of clinics quite a lot. So I'm going to focus on family practices that have exam rooms. In family practice, it's relatively simple. To run a clinic effectively, you want patients to be roomed, prepped, and waiting in an exam room when the physician is ready to see them. And the traditional solution is to simply assign each physician 2 rooms for the day or half day, and they bounce back and forth between those 2 rooms. This actually explains one of the key things I shared about our case study clinic pre-innovation. They have 11 rooms and 7 full-time physicians, but only 5 physicians could see patients at any one time because they each wanted 2 dedicated rooms. Now, I don't think I actually need to define hot desking for this audience, but for those who aren't familiar with the term, it's basically referring to an approach where people don't have dedicated offices or desks even. It's a trend that started in tech companies, but it's definitely expanded. I know a lot of high-end lawyers who don't even have offices anymore. Applying this idea to clinics, the basic version of this strategy is already relatively common. Even pre-innovation, the 7 full-time physicians at this clinic didn't each have their own permanent room. They were assigned 2 rooms for the day, like I mentioned. What about taking it to the next level though, where all the exam rooms are shared in real time? Where instead of each physician having 2 dedicated rooms and bouncing between them, you have, say, 5 physicians sharing all 10 rooms and bouncing between all 10. Here's the amazing thing. Once you take this approach, you can actually sneak in a couple more physicians without a negative impact. So just like that, you've gone from 5 doctors sharing 10 rooms to 7 doctors sharing 10 rooms, another 40% increase in capacity. Well, here's the $1 million question though. How do you avoid the clinic descending into chaos? The answer is that room sharing works if you have real-time orchestration, which is something everyone here has seen in the real world without even really thinking about it. So let's think. What's an example? Think air traffic control at an airport. Think traffic lights synchronization that lets you magically hit 8 green lights in a row. Think about Uber automatically coordinating millions of drivers and passengers in real time around the world. Or Waze, calculating to the exact minute when you'll arrive, taking into account traffic lights, slowdown, and accidents. And also think Chime. That is, how did our case study clinic go from 5 to 7 doctors sharing 11 rooms at the same time without it becoming chaos? Well, they deployed Chime, including our dashboards and room tablets, to achieve real-time orchestration that coordinated the patients, rooms, staff, and physicians. Just like the bed tracking and patient flow software some of you may be familiar with from hospitals, but brought down to a level affordable for a single clinic to implement. Moving on. I wanted to turn next to hybrid care, and more specifically, how to sustain the virtual care component of hybrid care. Let's chat first about whether there's an actual problem. Didn't almost everyone successfully pivot to virtual first because of the pandemic? Here's my understanding. Basically, it's hard to actually make virtual care, quote unquote, work for all clinicians in the long term. For example, our case study clinic has shared with us that roughly half of their family doctors have wanted to pivot back to mostly or entirely in-person care because of the day-to-day friction of virtual care. At least for me personally, the friction points identified here don't seem a big deal, but hey, I'm not a clinician. But of this list, I get why patients who don't answer calls can be incredibly frustrating. The last one also resonates with me a bit here, because when I go to see my family doctor in person, I take the entire morning off because I know there's going to be a wait. But I'll confess, when it's phone appointments, I do expect them to be exactly on time. Obviously, that's going to create a lot of friction right off the bat. So why is this relevant to the topic at hand? I think I'm basically stating the obvious, but to be crystal clear, virtual care is a great way to reduce the effective cost of appointments, especially if clinicians are set up to work from home instead of at the clinic. If you can move the clinician, support staff, and the patient all out of the clinic, the effective overhead cost of the appointment can drop to almost $0. Yes, there's other costs, of course, but that savings of $8 per appointment as compared to the same appointment that happens in person on site is measurable. And again, Chime has played a key role in enabling this clinic's innovation in this area. In particular, our technology is used by this clinic to virtually orchestrate all appointments, including both in-person as well as the virtual ones. The examples above here borrow from restaurant waiting lists. You'll see we're giving patients a real-time estimate of how much longer they'll need to wait after checking virtually for their appointment. There's lots more to virtual orchestration, obviously, but long story short, it's lots of these little things trying to make virtual care less frustrating for doctors. So even as you can see here from this patient viewpoint of what's going on when they're checking in for a virtual appointment via Chime, is that we're tracking them every step of the way, giving them updates every step of the way, telling them exactly how long it's going to be with these numbers being alive. And the same thing is happening on the physician side. This way, the two are communicating via a third-party platform so that when the physician picks up the phone, the patient is there. And when the patient is waiting and it says 30 seconds, in 30 seconds, the doctor picks up the phone. Okay, so let's turn to one last topic. It's a bit complicated, but we're almost done. This fourth innovation has to do with copying Uber. And basically, it's how they match supply of drivers with rider demand. So let's say the hockey game lets out downtown. How do you get enough drivers out to meet that surge in demand? Uber uses automated real-time incentives. So can clinics do something similar? Well, maybe. Let's step back and talk about the problem first. And in this case, it's physician scheduling. Physicians need to be scheduled into the clinic to see patients. Every clinic needs to do this, obviously. The traditional solution for most people is to use a spreadsheet, carve up the week into mornings and afternoons and figure out a schedule, right? So let's look at this hypothetical schedule below. We have John, Jane, Mary, Thomas, Zishan. They're the existing doctors and they have their own existing schedules. Everything is great. There's no half day with more than 4 doctors working, so everything is okay. Now, pretend you're recruiting a new physician, Machiko, who needs to be able to work at least 6 half days a week. You'll go through the schedule and you can find her 6 half days to work, but only if she works Friday afternoon. What if that's a deal breaker for her? Is this really going to be a lost opportunity to grow? Before I share the solution that this clinic crafted, let me give you another analogy. People are like pom-poms. Bear with me. They're all different and are all soft and moldable, malleable as well. When it comes to scheduling people, if you impose a lot of structure, you'll only have room for so many. Instead, if you're able to remove some of that structure, you're able to fit many more into the exact same space. So let's go back to Machiko and the innovation borrowing philosophy. This innovation that we're borrowing from Uber is to find a way to remove some of the structure, to not force people to work fixed shifts, but rather to sign in and sign off in a more dynamic, flexible, auto-adjusting way. Okay. I know this is still probably confusing. Let me give you a hypothetical Friday schedule to better show you what I mean. The table here is with traditional scheduling. You have your 4 docs in the morning and there's no room for Machiko until the afternoon. But if we can remove the artificial structure of only scheduling docs by the half day, and instead think about it hour by hour, knowing that people actually have more nuanced preferences for when they actually start, stop, and take breaks. In this second scenario, you'll see that it's actually possible for Machiko to work a half day between 8 a.m. and 1 p.m. without causing more than 4 doctors to ever be working at once. You've magically accommodated her, and great, you've removed the last barrier to recruiting her. I showed you this slide earlier in the context of room sharing and hot desking, and my bet is that you're probably thinking the same thing again. Okay, this sounds vaguely possible, but logistically, how would you actually implement any of this? It sounds like a business consultant making up ideas that can't work in the real world. But the answer is basically the same. Chime's real-time orchestration made this possible for this client. In the same way that real-time orchestration let them have more physicians working at the same time in the same space, it also let the clinic drop most of their scheduling rules and just simply let physicians schedule themselves to see patients in clinic whenever they wanted. The clinic needed to impose a global cap on the number of appointments that could be booked to prevent the equivalent of a gridlock. But beyond that one rule, they let physicians independently decide when to work and trusted our system to automatically handle the rest. So it's Friday afternoon and there's only a single physician working, no problem. It'll run the clinic in a relaxed mode, quote unquote, and assign patients to exam rooms well in advance. But what if it's Monday morning and it's a full house? No problem. It'll run the clinic, quote, tight to the wire, end quote. Yes, there might be a bit of additional waiting, but everything will get done. The system won't fall apart. It'll be like morning rush hour. It's slower, but people still get to where they need to go. And so, briefly, before I turn to questions, let me sum things up. Okay, so in short, this clinic, by one, cross training their staff, two, expanding their hours, three, adding kiosks and other automation, four, implementing room sharing, five, sustaining virtual sharing, and six, removing their internal scheduling rules. This clinic was able to double their yearly appointment volume and have their operating cost per appointment, as in half of their original costs, all without needing to move or renovate. All of this made possible through our technology. So we're pretty proud of how we were able to support this transformation. And so I'm happy to have had the chance to share this case study with you. And with that, let's turn to some of the questions that might be popping up right now. I'll answer as many as I can. And I do invite everyone on this call to feel free to email me directly to set up a demo or just chat about your clinic specifically, because that's what happens most of the time with this, is they say, sounds great. What about my clinic? I get it. There's nuances. Let's talk about it. So with that, I think I'll pass things over to Ashley and see if we can do our best to answer some questions here.
Absolutely. Thank you, Adam.
Thanks, Ashley.
Great presentation. All right, so we have some questions coming in. Let's do our first one here. How did staff feel about moving from 9 to 5 to a staggered shift? This is a multiple question. Was anything done to accommodate their schedule requests?
Was everything done to accommodate? Okay, so the first part of the question, once we implemented this mountain of change, how did the staff first get affected by it? I'll be honest with you and I'll be frank. The initial reaction to this change was probably negative more than it was positive. I think because change in general kind of has that reaction. Luckily, we have the luxury of time having gone by in hindsight. Everyone is happy with it now. Everyone loves it. Everyone couldn't imagine going back to how it was before. A lot easier to switch shifts. The second part of the question, Ashley, do you recall what that was? Sorry, I lost my train of thought.
Yeah, absolutely. Second was anything done to accommodate their schedule requests?
Anything done beyond beyond this staggering of how it goes? Well, I guess what you could say is scheduling requests in terms of physicians will typically move heaven and earth to make that work. And with the way that we do the staggering alongside with the tech, it's pretty easy to accommodate those. There's always going to be, situations where that's not the case. But I mean, luckily you're dealing with adult professionals who can be open to a conversation. And maybe in the short term, we can't accommodate, but in the long term, we can typically accommodate all our staff with our staggered solution. Hopefully that answers.
Absolutely. We have to get used to change.
No one likes it.
Next question. Has there ever been a time where the system has broken down? If not, what are the guidelines put in place to handle systems downtime?
Wow, that's an amazing question. Okay, so has it broken down? I'm going to say no, because the phrase broken down sounds terrifying to me. Has it glitched? Yes, it has glitched. Each glitch makes us stronger. We've been around, we're coming up to our 5th year now. The glitches now that happen, they are new, they're novel. Any problems that we've had in the past, we have automatic systems in place to offset that. To part B of your question, if something were to go wrong and you're in the middle of your clinic being open or anything's happening, you can get a hold of anyone at Chime immediately. Okay. We have 100% retention rate with all of our clients across Canada, which means they renew with us year after year. And I think one of the reasons is all the baseline parameters in place, but we end up configuring a new rule or a new system because a clinic has a great idea. Hey, what if Chime did this? And we say, I think we could do it. And then we build it and it's great. But then at some point, sometimes that glitches, we fix it and it's done. Thanks, Ashley. I think I answered it.
Yeah, absolutely. Here's the next one. Which EMRs does Chime integrate with?
Oh, more good questions. Okay, so we integrate with pretty much every EMR across Canada. Our direct integrations, wherein the integration is seamless and requires no human involvement, would be anything TELUS related, as well as Well Health, so your Oscar platforms. We integrate directly, so the system will essentially sync every 4 to 5 seconds to make sure it's speaking to each other. Anything that happens in the EMR happens in Chime and vice versa. For the other ones, your MedAccess, for TELUS, your Accuro, we integrate with all of them, but on an as needed basis. So you might have an EMR that we, in theory, have integration with, but we haven't had to initiate it yet, in which case we probably have to go back and confirm all of our integrations can happen. But on a sub level, we can integrate with any EMR as a workaround regardless. We can create a manual sync. So as opposed to it happening automatically, we can create a manual one, which just takes an extra second of somebody's day. It's really not that big of a deal. But chances are we integrate fully with the EMR you have.
All right, great. Thank you, Adam. Next one. What's your prediction when it comes to costs and the future?
I would have to say that the status quo is probably going to remain how it is. I think what we're experiencing now is going to be something that we experience in the future. Okay. I think that the idea of, I'm trying to think of how I want to put it perfectly. I know I'm on a webinar. I tend to stop and think before I answer, but everyone yells at me, hey, you're on a webinar, that's downtime. So I guess what I'd say is it's going to be a lot more of the same. Costs are going to keep rising. Our reimbursements aren't going to come in that are going to sync up with the new costs. And if we don't start implementing solutions that are transformative, I think the industry is going to be in trouble. I think we need to make sure that if things are what they are now, are we implementing daily solutions that are really just Band-Aids over cuts that have to get replaced every single day that we come into work? Because there's lots of great technology that you can use that just offsets what you're already doing. But the real transformative change of the future is going to come with technology that changes the way we do things on a day-to-day basis. And I think that's what the future is going to be. I don't even know if that's going to be Chime, but it's going to be something along those lines where we say, wow, this is how we've always run clinics. But thanks to where technology is today, this is how we can run them going forward. And yeah, it's going to be completely different, but it's going to work better. Thanks, Ashley.
Awesome. Thank you, Adam. So how was the change managed across the staff and the physician team?
So that is something that every time we bring Chime into a clinic, that's one of the big aspects of the installation and training is working with the staff and the physicians to implement these changes. It is so with staff, it's easy. These are employees, and essentially this is the new process, and you explain the new process and they learn it and they adapt. With physicians, it can be a lot more difficult because you're changing their day, and they don't want to change their day. They want to treat patients, and rightfully so. This is what they want to do. But what happens is we work hard with the physicians. That way, the clinic owner, the clinic manager, they're not working with them as a third party, and there's nothing lost in translation. There's no us versus them feeling we're coming in to support them. And that's the energy we try to have. Hey, isn't this great? Look how much better your day is going to be. Look how much more patients you can see. Look how much happier. So we try to really control it in that sense. At the end of the day, people always fight us. Some people don't fight us. It's technology and it's change. But once enough time goes by, you can't find a physician who will admit that they were against it in the first place, because things just run so smoothly that eventually oh yeah, I was always for that. I was always for it. So I think at the beginning, you should be ready for a bit of a pushback against the change, if I'm being honest.
Wonderful. Okay, we have a few more questions left here. Do you think that this model / learnings could be applied to emergency departments?
So I would love that to be the case. ERs have so many complicated nuances beyond like a family clinic. from a perspective of somebody involved with Chime. So to speak to Chime specifically about ER, it doesn't work well in that setting. There's just too many parameters that would have to go in. But Chime's technology, the idea behind Chime, I think the future of ERs will be there. And in fact, I think right now in Quebec, the Ministry of Health is putting together a team to identify if there's an orchestration software that can help relieve a lot of pressure that they're feeling in their ERs in Quebec, which is they're really being overrun. And they're trying to create a situation where essentially people can come into the ER and be sent home because a Chime-like system is going to tell them, hey, head back it's going to be ready at 3:15. Your blood's going to happen then. You're going to wait for 45 minutes, then you're going to go here. And that's what they're working on right now. So I do think that's going to be the future.
Okay, wonderful. If anyone has any last minute questions, feel free to put it in the chat box. All right, so we had one that just came in. What were the process? Were there process changes outside of Chime that enabled the management of the additional capacity?
Yeah, for sure. Well, the scheduling one, really, I mean, for that scheduling, you can definitely do it without Chime, but you would probably need to bring on another staff member to offset the straggle. So that was something that we worked out together with the idea of that they could do that with or without a Chime solution in place. So when we set up their staggered staff scheduling, the idea was it could work without Chime, and it can work without Chime, but with Chime, it just happens to work a little bit better. The physician model couldn't really change. The other changes they made that had nothing to, well, they did find themselves not needing, they had 3 MAs. No, well, they needed Chime to get rid of the MAs at that point. Yeah. So I think the only change they really made was staggering the staff outside of tech, outside of a technological solution there. Thanks, Ashley.
Okay, wonderful. So have these strategies helped with recruitment and staff retention?
Yeah, big time. So, I mean, I think retention is one of the biggest problems that faces Canadian healthcare right now. So what you do when you have these situations where you can entice a physician to come in, because now you can say, hey, when do you want to work? Okay, guess what? We can make that work for you. And then you kind of show them how it can be done. And they say, okay, great. From a staff point of view, your MAs, et cetera, what they can do now is they can dedicate their job to more high value tasks. Okay, I'm sure everyone knows that someone sitting at that front reception desk, 80% of their day is spent telling people that they're not forgotten about, we're going to be right with you, not to worry, or walking them to the right room. Okay. A job like that, if you think about it, of course, it's a bit of a revolving door. You know what I mean? That is a step job. That is something you do for a while, and then you have been maximized at your potential there, and then you move on. With Chime involved taking on those kind of tasks, that staff gets to be a more prominent member of the staff. They have high value things that they can undertake. They're tasks we can give them that are more important to the clinic. Okay, the running of the clinic, which helps with retention. And obviously it helps to have like a modern high tech facility that runs well. It helps to keep managers. Okay, because if your baseline clinic is run by tech, you don't have to wake up to 3 people calling in sick and you having a heart attack as the entire day rests on your shoulders running around doing a job of 5 employees who didn't show up that day. Okay. All of these things help with recruitment and retention at the same time.
Okay, great. Could you tell us more about the Central Hub device installed physically at clinics?
Yeah, sure. And just so everyone knows, because there's been a few questions that are actually super specific and good, but that are also answerable on our website. If you want to hear the next level of details and everything like that, we have all this stuff on our website. So as it relates to the Central Hub, this is essentially us to ensure that if there's any kind of power outage or internet outage, that Chime will still be able to function for you. So in a nutshell, that's what it does. But the schematics and all the numbers on it and everything that I don't know as well, you can definitely find on the website. And if you want to email me because you're just interested in specific details, I'd be happy to send a link or anything like that over to you.
All right, great. What are the biggest concerns physicians has expressed regarding hybrid care? And do they seem concerned with cost reduction?
Interesting B point to that question. I don't think I've heard any feedback where the physicians who aren't like clinic owners or anything are concerned with that, with the cost reduction aspect. Interesting question though. On the first part, which is, what kind of concerns have we seen with hybrid care? I think the biggest concern that physicians have is one, that they want to make sure they're actually providing sufficient care to their patients. Okay, and that can be difficult with a phone call, especially if a patient doesn't know how many levels to get into and things like that. So that's a nuance that's solvable within the physician-patient relationship, like that conversation of what kind of things can we be saying, what kind of expectations can we set. But the other problem that we have is that when physicians don't, and I don't mean to attack physicians in any way, this is just anecdotal, is when physicians equate a phone appointment to something less important than an in-person appointment. And this might not be true across the board, but I have talked to a few physicians at some clinics who are asking me how to use Chime when they're, doing calls from their car and stuff like that. And our philosophy is we really don't support that level of healthcare. The idea that let's make phone conversations something a physician could do on their way to run errands or anything. So I think one of the ways that we deal with that is by creating these dedicated spaces that physicians can be in and treating these spaces as if they're with an in-person appointment. So dedicated office space, silence as needed, the right amount of time for that appointment to happen, and a physician treating it with the same seriousness that you would treat someone waiting in an exam room when they're waiting on hold for you. That might not answer it specifically. I might have been a bit around, but it was a really interesting question. I'm kind of like thinking about it as I answer, but I might think about it more. In case you, person who asked me that question, in case you want to shoot me an email or something, I'd be happy to get you some more answers on that.
Wonderful, thank you. And are clinicians involved in the technical requirements of Chime before implementation? If so, how?
Another good question. So they're involved in only in sense of what should the system be doing? Well, what are its capabilities? And really, so when we talked about one aspect of the Chime, I'll be super quick here, don't worry, is all the rooms have iPad or tablets on them. And so on those tablets, that's essentially letting the system know what is going on when. And so a clinician might check in. But beyond that, they might have to tell somebody, hey, we need to weigh a baby in room 7, or let's take some blood for this patient, XYZ. So for that, we have pre-populated things within the iPad, very easy to use. One click, list pops up, you select it. But like I mentioned earlier, every clinic has this little nuance, which means that we have to work with physicians early on to say, hey, what are we missing from here? Is there anything that you do specifically with your patients that isn't auto-populated on here? Beyond that, physicians don't need any involvement with the tech whatsoever. We made it simple. On our side, incredibly complicated stuff we're doing constantly for them, but on their side, it looks like everything worked with clicking one button. Thanks, Ashley.
Great, thank you. All right. Did physicians have concerns about the resulting administrative work from seeing more patients?
No, we haven't had any feedback like that. I think when clinics flow the way they can, it doesn't seem to feel any different from the physician side of things.
All right, so that is it with questions. We do have time, so if anyone has any further questions, feel free to type them in our chat box. So I'm going to take this opportunity right now just to show you what is upcoming and
great.
Digital Health Canada World. So here is the list of the upcoming webinar Wednesdays. We have all the way up until December 14th. And these are the webinar Wednesdays that are up and active in our on our website. So feel free to take a look at our descriptions, our upcoming speakers, and register. And we also have another lineup of link ups, one for Saskatchewan, BC, and Atlantic coming up. So please keep an eye out for that. Registration will open up soon. Okay, so this is the time. If anyone has any last minute questions, please feel free to type it in the chat box. If not, Adam did, as he had up his email address, feel free to reach out to him directly. You can also find him on LinkedIn, or feel free to send an email out to webinars@digitalhealthcanada.com if you have any questions, and I could pass it along to Adam. All
Awesome.
right. So no other questions. Adam, do you have any final words for everyone?
Yeah, final words is, I think just so everyone knows, I don't know on this call if people are clinic owners, managers, physicians, third party, tech entrepreneurs or whatever. Rest assured, I talk to clinics across the country every day, all day, and we are all somehow experiencing the same issues where staff retention is a huge deal. Being able to find physicians and recruiting them is a huge deal. I know BC is trying to make some changes in how they're remunerated, but everyone's behind on it. So we're all in the same boat currently, where's the revenue? This is too hard. What is going on? Where's my staff? But I think if we all stick together as a community, which I've seen is kind of the feel and vibe of our industry, that we are going to weather the storm and come out better on the other end. It's just a weird time, it's just a weird time. But again, Ashley, thank you so much. I thank you so much for joining, everybody. I mean, this is someone's lunch hour. I take that seriously. I work all day for my lunch hour. So the fact that you're here is a big deal. And please reach out. Ask me silly little questions about your clinic. That's what I do. Happy to. Thanks, Ashley.
Awesome. Thank you, Adam. Thank you to all our attendees for being with us here today. And we'll just see you all again next week. Have a great afternoon, everyone. Thank you.
Cheers. Bye-bye.
See you, everyone.